last lecture, I discussed about bradycardia. So bradycardia is when heart rate becomes slower than 60 beats per minute. So then 60 beats per minute is bradycardia. An important cause of bradycardia is that it is seen in trained athletes and players. So athletes and players, it is seen. Some of the world famous tennis players, their resting heart rate is in 30s, 38 beats per minute. This is the resting heart rate, some of the tennis players of the world. What is the mechanism of this physiological bradycardia in athletes and sportsmen? Now in sportsmen and athletes, their heart is stronger. Or you say their heart is physiologically hypertrophic. So with stronger heart, their stroke volume is increased permanently. And their stroke volume is increased permanently. So increased stroke volume, of course their resting cardiac output is same as in other people. So cardiac output is maintained to normal values in athletes having increased stroke volume by producing bradycardia. You know, there is an equation that is cardiac output is equal to stroke volume into heart rate. Cardiac output is equal to stroke volume into heart rate. So when there is increase in stroke volume, and that increase is permanent because heart is stronger, so then this cardiac output is maintained at rest by producing reflex bradycardia by slowing down the heart rate. So this is the mechanism of physiological bradycardia in athletes and sportsmen. No other causes of bradycardia includes hypothermia, vagal stimulation, say in vomiting there is vagal stimulation, there is bradycardia. Parasympathomimetic drugs, sympatholytic drugs, hypothyroidism, and increased intracranial pressure. So these are the causes of bradycardia, right? Our next abnormality which we will discuss will be atrial flutter. In atrial flutter, atria beat regularly at a rate of 250 to 400 per minute. So atria beat regularly at a rate of 250 to 400 per minute. Now all these impulses from the atria cannot pass to the ventricle. So all these impulses from the atria cannot pass to the ventricle. Every second or third impulse passes from the atria to the ventricle. I am saying every second or third impulse it passes from the atria to the ventricle. So ventricle rate is say 125 per minute. Atrial rate 250 to 400 per minute. Ventricular rate is 125 or 150 per minute. And keep in mind, every second or third impulse, it passes from the atria to the ventricle. So in the ECG, you can see that after every 3 P waves, there is a Q, R, S, and then T. Right? But the other feature is that the P waves are typically sawtooth shaped. You see? P waves are sawtooth shaped. Sawtooth shaped. And every, say, 3 P waves, there is a Q, R, S, T. So this is called 3-to-1 rhythm, or it may be 2-to-1 rhythm. So 2-to-1, or it may be 3-to-1 rhythm. Right? So this is atria flutter in which atria beat regularly at a rate of 250 to 400 per minute. All impulses from the atria can't pass to the ventricle. Every second or third impulse passes to the ventricle. So ventricle rate is 125 to 150 per minute. Right? So in the ECG, P waves are sawtooth shaped. And after every 3 P waves, there is the Q, R, S, T. So it is a 3-to-1 rhythm. After every 3 P waves, there is the Q, R, S, T. So 3-to-1 rhythm. So this is the atrial flutter. Now the disorder is atrial fibrillation. Atrial fibrillation. Now in atrial fibrillation, atria beat irregularly. Atria beat irregularly at a rate of 400 to 600 per minute. So atria beat irregularly at a rate of 400 to 600 per minute. Impulses from the atria are conducted to the ventricle irregularly. Right? So impulses are conducted from the atria to the ventricle irregularly. Ventricle rate may be 125 to 150 per minute. So ventricle rate is 125 to 150 per minute. Atrial rate is 400 to 600 per minute. Now in the ECG, you see, P waves are replaced by small irregular waves. P waves are replaced by small irregular waves. Small irregular waves. And unequal distance between QRS complexes. You see, the interval or distance between QRS complexes is unequal. You see, less distance, less interval, more interval. Right? So, unequal distance or interval between successive QRS complexes. So, moreover, atria beat irregularly and atrial contraction is ineffective. It is not coordinated contraction of the atria. Atria beats in parts. Atria beat in parts. Right? So when there is atrial fibrillation, of course, atria beat irregularly, ineffectively. Right? Diastole is shortened. The rest is not given to the heart, and ultimately in these cases there is heart failure. So heart failure occurs in cases of atrial fibrillation. Now the peripheral pulses, arterial pulse or radial pulse, it shows pulse deficit. Pulse deficit in the radial pulse. What is pulse deficit? The heart rate recorded at the apex of the heart is more than the heart rate at the radial pulse. So heart rate determined at the apex of the heart is more greater than the heart rate at the radial pulse. Actually, weak heartbeats are not transmitted to the peripheral arteries. So weak heartbeats are not transmitted to the peripheral arteries. So that is why there is pulse deficit. Say at the apex of the heart rate is say 125 per minute. At the radial artery, the heart rate is say 100 per minute. And this is called pulse deficit. Pulse deficit, that heart rate at the apex of the heart is greater than the heart rate at the radial artery. So this is the ECG in atrial fibrillation, small irregular waves replacing the P waves and unequal distance or interval between successive QRS complexes. Next abnormality in the ECG, which is very important clinically, is ischemic heart disease. So in ischemic heart disease, what changes occur in the ECG? Ischemic heart disease is of two types, angina pectoris and then acute myocardial infarction. So angina pectoris and acute myocardial infarction. In angina pectoris, there is cardiac pain on physical exertion or during emotional stress. There is cardiac pain. And this cardiac pain is felt behind the sternum. It radiates to the left shoulder, left arm. Right? And this compels the patient to take rest. It compels the patient to take rest. This is the angina pectoris. Now in angina pectoris, in many cases, ECG is normal. So in many cases of angina pectoris, ECG is normal. But in some cases of angina pectoris, ECG shows inversion of T wave. So T wave inversion is seen, negative T wave is seen in angina